And for this talk, I'm going to be presenting on behalf of Caleb Hahn, who couldn't be here. He's unfortunately taking the medical college admissions test, which is the main test that you need to get into medical school in the United States. So that's funny because there's no H in MCAT, right? So yeah. So these are my disclosures. Nothing is relevant to the work that I'm going to be giving today. So when we talk about MoyaMoya disease and syndrome, and for those that are unfamiliar with this, this is fundamentally a non-atherosclerotic intracranial vasculopathy. And it can be either a disease, so that means it's idiopathic, so it's not secondary to anything else, or it can be syndromic. And it's kind of a relatively common secondary condition to things like sickle cell disease, Down syndrome, neurofibromatosis, radiation therapy. There's some other things as well. And then what happens here is you get stenotic occlusion of the supraclinoid internal carotid arteries and also the proximal branches, primarily the anterior circulation. And as a result, you develop these elaborate networks of collateral vessels. And then these patients, as you can imagine, are at very high risk for new or recurrent strokes. This is just an example angiogram here of MCA stenosis here, and then also the development of these lenticulostriate collaterals. So why would you want to study that? Isn't that kind of rare? And it is, but it's not as rare as you might think. And what's interesting about it is that the therapies are really not supported by randomized clinical trials. So the conservative treatment is basically nothing, and it's sort of keeping them hydrated and so forth. And then for more symptomatic patients that are having ischemic symptoms, that's surgical revascularization, and I'll get into that a little bit more. But the general goal is to enhance the cerebral blood flow to the tissue. And the reason that novel imaging is particularly relevant here is because we don't have good methods to triage these patients for surgeries, different types of surgeries, or more conservative treatment. So the idea that you can do new imaging to help inform that decision is especially important. And what we do to look at that is primarily looking at the compensation mechanisms that are going on at the parenchymal level. So in these patients, it's well known that if you look at an angiogram, they're going to have stenotic occlusion of some of these vessels. But then what's more interesting is like what's happening, how does the brain actually compensate for that at the tissue level? And the brain's tremendously clever about how it can do that. So if you zoom in here, you're going to see like the arterioles, which are surrounded by nice smooth muscle and so forth. They're about 30% of the total blood volume. And then there's also the veins that are about 70% of the total blood volume that don't have that smooth muscle. So when you have this stenotic occlusion, what will happen is at the tissue level, those vessels will dilate in order to try and get more blood to the tissue, cerebral blood flow. But it can only go so far. And then if you have a proximal, a further reduction in perfusion pressure or further stenosis, and the brain's not able to compensate, and you could have a stroke. So those are the things that we look at, and we talk about that in terms of supravascular reactivity, which is really just in general terms. It kind of means the ability of the vasculature to dilate and constrict. We've heard a lot about that. And then kind of more specifically, which is often sometimes abbreviated CVR as well, supravascular reserves. That's how much microvasculature can increase the blood volume further in order to compensate for that proximal stenosis. Is it maxed out, or does it still have a ways to go? So the way that we've been measuring that at our hospital is with supravascular reactivity mapping with hypercapnia. And we've gone over this in some of the other talks, but generally the idea is that you're going to give a CO2 stimulus. We do it twice for 180 seconds each time. You're going to get an increase in your end tidal CO2 that goes up by about 5.5 millimeters of mercury for our stimulus. And then you can also see the signal changes in like two different regions here for like bold over time. And in the red region here, you can see it goes up later, and then it also gets to a lower point. And you can quantify that information by taking a regressor, and this can be a global signal regressor, different things. We use a regressor, or what I'm going to talk about today is using a regressor that's correlated with the stimulus delivery. You then just progress that in time, and you calculate correlation, z-statistics, and so forth. And then you see where is that z-statistic maximal, and then also how long does it take to get there. And if you do that, it gives you some information about what we call the CVR raw. So that's if you just do what most people not in this room probably do, which is where you don't do any time regression analysis. And then you can also look at the CVR max. So that's when you progress this in time, whereas the maximum reactivity, and then also how long does it take to get there, and that's the CVR delay. And this is just an example of what these maps look like in a patient with an asymmetric stenotic occlusion on the left side here. You can see the CVR max is reduced, and the CVR delay is increased. This is using a method similar to what Blaise Frederick first proposed a few years ago. Okay, so what we do in the clinic actually is we make nice little movies of these things. So this is an example of a surgical revascularization in a patient with left M1 stenosis. And I'm just going to show kind of what this time regression analysis looks like. You can see the vessels reacting on the right side here. It takes much longer on the left side. That's consistent with the stenosis, delays in smooth muscle function and so forth. And then after the surgery, which was relatively successful, you can see how much faster it feels now in the contralateral hemisphere, right? So you can visualize the timing of those things and then also the magnitude of the response, how bright those voxels get. And you can confirm that also on like a catheter angiogram or so forth, where you see nice revascularization after the surgery. But really the fundamental question, like when we do this in the clinic, is it useful for anything? These are kind of cute maps and so forth, but what you really want to know is, does it correspond with symptoms or ideally future stroke risk? So what Caleb decided to do for the study was to evaluate patients with MoyaMoya vasculopathy with and without focal neurological symptoms in the prior 6 months. So he's looked at asymptomatic and symptomatic patients. And the hypothesis was that the CVR is reduced in the flow areas with versus without these recent neurological symptoms. And then also the CVR delay from this time regression analysis is more sensitive to the symptomatology than just the CVR alone. And if you confirm that, it's kind of important because it really motivates CVR and these different timing delays potentially as a biomarker of potentially stroke risk, but also after a surgery, whether you see normalization of these parameters or not. And if you know that those things correlate with symptoms, then that's a potentially important finding. Okay, so what did we do? So we had 73 participants that were enrolled from our neurosurgery services. Those patients got clinically indicated catheter angiography. They just got a basic BOLD scan as well, and that was with hypercapnic gas stimulus. We've also been interested in looking at, for the last 10 years or so, using hyperoxia as a contrast agent. So I'm going to talk a little bit about this too, balancing this with oxygen, why that's useful in some cases. And then also we did a time regression analysis to look at these different parameters. Just as a quick aside about the stimulus, because different stimuli will elicit different responses and different people will use different things. If you use a hypercapnic neuromoxic stimulus, that's what's shown in black here. So these are our data from about 15 people or so. You get maybe a 4 to 6% signal change in healthy tissue. It's pretty reproducible. If you then balance that CO2 with oxygen and air, you're going to drop your deoxyhemoglobin a lot in your veins, and you're going to get a much larger signal change there. And a lot of that signal change has nothing to do with reactivity. It's a sort of an artifact from the hyperoxia balance. And then what you can also do is you can just get pure hyperoxia, which is shown in these green blocks here. And then you could even interleave that with like carbogen or hypercapnic hyperoxia as well. And that signal change here that you get is a bit similar to a normal hypercapnic stimulus as well. So why would you want to do something a little bit more complex like this in terms of the interpretation? Well, there's a couple of reasons. The interesting physiological reason is that this oxygen acts as an endogenous bolus. Actually, you can actually track that as it goes through the vasculature. The other kind of more practical considerations is that this protocol is now a clinical protocol in our hospital. We have to use it with kind of FDA-approved oxygen face mask, clinical tubing, and so forth, delivering it from compressed cylinders. So practically, this is also a mixture that you can get from most gas vendors certified for medical use, and you can use it in a clinical setting. But it's important to know that there are variations with this stimulus versus others. We've looked at that in detail. So if you look at like the signal change versus this stimulus versus a basic hypercapnic normoxic stimulus across different brain regions and participants, you actually see that it's pretty tightly coupled. So it's significantly correlated, but it's not one-to-one. So this is like a line of unity here. So it's important to know that you do get different signal changes, and they are much larger. If you look across different regions, so different brain lobes or so forth, you also see generally the same trends for both the hypercapnic normoxia and the hypercapnic hyperoxia as well. So what I would just say from this kind of aside is that the contrast mechanisms of these differ. We can talk more about that if people are interested. So you want to take a little bit of care in transposing findings from one stimulus to another, but they're generally correlated. So the methods in terms of the analysis, so we had a board-certified neurologist look at symptoms. They categorize the symptoms as either focal ischemic symptoms within the last 6 months or asymptomatic. Hemispheres with ischemic symptoms that were greater than 6 months were excluded. We then calculated these same parameters, the CVR raw, max, and delay, and we did that in different flow territories and different hemispheres. And then we also, if they did have a prior stroke, we used the segmentation from the flare to exclude that tissue. So we're not looking in infarcted tissue, we're looking in health or viable tissue. And then we did a logistic regression analysis just to compare these values across the 2 different groups after comparing for age and sex. Okay, so what it looks like in terms of the results. So we got initially 146 total brain hemispheres. Some of them have older infarcts, strokes, 37 of them, so we took them out. And then we looked at the symptomatic hemispheres and the asymptomatic hemispheres, took out the infarcts and the symptomatic hemispheres if that was necessary, and then we compared the parameters using logistic regression. And these are the results. So in the end, you're going to be looking at data from 59 asymptomatic patients, 32 symptomatic patients, and then grouped by hemisphere. You get about 109 hemispheres or so. They're pretty well matched for age sets. MoyaMoya affects females 3 to 1, so we see that here as well. And interestingly, it's a North American phenotype that we have, so we have a lot of Black and white participants, far fewer Asians. That's kind of interesting in itself. And part of that comes from the fact that we have a relatively limited referral bias for research, because this is a clinical protocol. So all of these patients get this scan clinically. So you don't have to worry about like only the patients that want to participate in research come and volunteer. We get kind of all comers for the most part. All right, so what it looks like. If you first look at that CVR raw, so that's what kind of everybody in the past would do without changing the regressor, you can see that the reactivity is higher in the asymptomatic cohort versus the symptomatic cohort. If you can decompose that down into the maximum reactivity and the delays, you can see that there is also an increase in the maximum reactivity in the asymptomatic versus symptomatic, but it's smaller. And then if you look at the delays, they're much longer, actually, in the symptomatic cohort. And these are the results of the regression analysis after controlling for age and sex. And what you see is that the delays actually are some of the most significant findings, actually. And this maximum reactivity is much less significant. Technically, if you correct for multiple comparisons, it goes away. So, we see a stronger finding with the CVR delays. This is an example of what that looks like. So patient, 57-year-old female, right M1 stenosis. This is their flare. So they've got some kind of scattered diffuse chronic ischemia here. They've got an M1 stenosis. This is a sort of capillary blush phase after a right ICA injection. And then if you look at the maximum reactivity, you can see it's reduced on that side, and the delay is also increased, like you expect. Okay, so then just in the last minute or two here, what we also look at is, if you have this information, can you use it to identify whether patients are getting better after their surgeries? And one of the surgeries for these patients is something called an indirect surgical revascularization. So it's done at our hospital with something called an EDAS, that's an encephaloduro-arteriosyngiosis, where you'll lay a branch of the superficial temporal artery onto the brain. It'll promote new vessels over time, but that's highly variable. So if you look at some patients, they have basically no sprouting of new vessels over time. Some do a little bit better, and then some do a lot better over time. And what we'd like to know is why is that, and can we quantify that in these patients? This is just an example of what that looks like. This is the patient with kind of robust surgery, pre-post. You can see the new vessels that are forming here. And if you look at the reactivity delays pre versus post, you can see they go way down. And the reactivity near the site also goes up a bit. This is a patient that had a much poorer response. You can see they don't revascularize as well, and their delays don't change much. Maybe they get a little bit worse, and also their reactivity doesn't change. And because we now have all the data in symptomatic and asymptomatic hemispheres, you can actually create age-dependent norms. It's a little bit similar to like neuroquant, which is what's done for tissue volumes. And you can now plot each patient that you scan, both those symptomatic or asymptomatic hemisphere, or left, right, however you want to do it, across age-dependent norms to see kind of semi-quantitatively where they fit. And then if you do the surgery, do they change? So you can see this is a patient where the blue hemisphere, for instance, the right hemisphere, has a much longer reactivity delay. It's outside of a normal asymptomatic range, and then the reactivity is a little bit low there as well. Good. So just to end then, so Caleb looked at MoyaMoya disease and syndrome patients. Again, that's a non-atherosclerotic intracranial stenosis. The treatment decisions and outcome assessments are not really supported by random clinical trials. And then neuroimaging in MoyaMoya disease and syndrome, we used hypercapnic bulge for the reactivity. And then what was a little bit novel is that we did time regression analysis to decompose that into the kind of the maximum reactivity and these kind of CVR delays, which are kind of like the dispersion of the response. And the finding was that in those that had recent ischemic symptoms, the CVR delay in the flow territory with those focal symptoms was quite long and significantly lengthened relative to the contralateral hemisphere. Maximum CVR was also affected, but it was less significant. We also provided some age-dependent norms. Overall, now I think there are other groups here, obviously the Toronto group that does a lot of this, but we've done 248 patients over about 13 years with MoyaMoya, 427, most of them are MoyaMoya, a few of them not, 427 total scans. We haven't noted any neurological adverse events as a result of the stimulus. And it's actually now, accepted as a diagnostic scan at our hospital. It's kind of exciting for a lot of the developments from people in this group went into that. So I'll go ahead and end there with the acknowledgements. These are our collaborators in neurosurgery and neurology, members of my lab, and then also in diagnostic radiology. And again, I give the talk, but Caleb was the one that did all of this work. So thanks.